There are four commissioners here in room 100 and the rest are participating via Zoom. Given that this is a hybrid meeting, some additional ground rules will still apply. I'll begin the meeting with a roll call of the commissioners. During the meeting, I ask that people speaking please identify themselves before doing so. That way commissioners and members of the public will know who's speaking and have the same knowledge as if they were here in room 100 with us. All commissioners are permitted to be unmuted and speak at their discretion. The public and most staff should please self-mute and may not speak unless recognized. Due to the possibility of background noise, I ask the commissioners and others please mute their phones when they are not speaking. I'm guessing that some of the background noise that I'm hearing right now or echo may be from unmuted phones or computers. So please check and make sure that you're muted. Most of the documents will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the website and on our various social media channels. I will now call the roll. Commissioner Akintade.
Present.
Commissioner Boyer. Commissioner Boyer. Commissioner Cheatham.
Present.
Commissioner Dorton is here with us. Commissioner Jensen is here with us. Commissioner Metz.
Yes, sir.
Commissioner O'Connor, I heard you before. Commissioner Sargent, to my right. Commissioner Wang.
Present.
And Commissioner Wood.
Present.
Welcome, Commissioner
Dr.
Wood.
Pollack, this is Commissioner Bandari. I think I missed it.
Yes, I acknowledge that I could see you.
Thank you.
Today, I want to welcome Commissioner Kerry Wood to the MHCC. Commissioner Wood resides in Charles County and is Executive Vice President and Director of Business Development for the Community Bank of the Chesapeake. In addition to her work with Community Bank of the Chesapeake, Ms. Wood has extensive experience working with community organizations in Southern Maryland. That perspective will be valuable to the Commission as we consider delivery system issues of importance to Southern Maryland. Welcome, Commissioner Wood. A new Assistant Attorney General has joined the Commission. Sarah Pendley, Senior Counsel to MHCC, will provide an introduction. Sarah.
My pleasure to introduce you all to Alexa Bertinelli. She's the new Attorney General that will serve as counsel to the Commission. Alexa comes to the Commission with a wealth of 10 years of experience, mostly in public service law. She's been an attorney for the Maryland Legal Aid and most recently civil justice, which demonstrates her commitment to serving the public using her legal skills to serve the public. Alexa graduated from the University of Texas School of Law, and during her time there, she had some notable achievements. She was editor-in-chief of the Texas Journal of Women in the Law. She was awarded the Dean's Achievement Award for the highest grade in higher education in law and an endowed presidential scholarship in law. So I welcome her. I've been working with her the last week, and we're already getting a lot of things done. It's a great.
Thank you. Welcome, Alexa. Welcome. Included in your packets are copies of the minutes from the February 24, 2022 public meeting of the Commission that took place in person and by video conference. I think that was actually all by video. I'll now entertain a motion to approve the minutes of the February 24, 2022 Commission meeting.
So moved.
Commissioner Jensen. Second, Commissioner Dorton. All in favor?
Aye.
Aye.
Any opposed? Great. The minutes of the February 24, 2022 public meeting of the Commission are now approved. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Does the executive director have updates for us?
Thank you, Dr. Pollack, members of the commission, both present here in the room and on the line. First off, I want to note that our chief counsel, Sarah Penley, will be leaving us in early April to take a position. We do have some feedback, and if you are on the phone or coming through on Zoom, please mute your phone. We are going to be losing Counselor Penley in early April. She's taking a position as chief counsel at the Department of Aging. Despite my protest, she did point out that chief counsel positions are highly sought after, and it definitely is a promotion. So we wish her all the very best in her time with the Department of Aging. I'm sure she knows we appreciate all of her efforts over the last 4 years, and she realized she continues to have many friends at the Maryland Healthcare Commission. So all the best to Sarah.
Thank you. Thank you.
I wanted to cover a couple things. One is more of a, just to give the commissioners kind of an update, an outlook on the commission staff's activities over the last 2 years, really. We have become increasingly engaged in a variety of collaborations with principally within the Department of Health that we are responsible for participating in, but do not directly inform the commission on. And I wanted to go through those very briefly. The executive directors, I serve on the governor or the secretary's vision group, which is that Secretary Schrader has pulled together to look at the broad swath of healthcare reforms that are being launched in the state. It's not a decision-making body, but it is informational. And I think I've begun to send those information packets out to the commission. If you have questions on that, please let me know. And if there's particular detailed information you need on any one of the initiatives, I'll be happy to pull that together. We also serve on a number of subgroups with the HSCRC payment models group, the quality reporting initiative, population health effort. We're going to think about, in terms of staff, how we keep the commission informed on those activities. As you know, the statute specifically says the commission is a decider, but as we are increasingly collaborative, we recognize that it's our belief that the commission would want us to participate, to offer both the capabilities of the commission, but also to gather information to bring back to you all on what's happening. And with the formation of the Shirley Nathan Pullian Commission on Health Equity, Tracy DeShields is serving on one of the data subcommittees that has been formed off of that group. And it's our hope that we can closely integrate some of our data collection activities with some of their information needs. In addition to that, there are more formal agreements that have been underway. The Maryland Primary Care Initiative, which David Sharp plays a key role in terms of convening advisory council. We expect that the next track, the next so-called track, which is the next phase of this model, will be we'll be getting some feedback from CMMI in April or early May in terms of how we go forward with that, and we will keep you informed on that. I also participate on a request basis for a variety of efforts that the secretary pulls together. The most recent is an illustration of that, is an informal group that's looking at resolving some of the challenges that Medicare Advantage programs are facing here in Maryland. Historically, Medicare Advantage is not the concept broadly, which is a managed care program for the Medicare population. Is not done as well as it has in other states, but now we're inching up to over 200, about 200,000 Medicare beneficiaries are enrolled. And the Advantage plans here have struggled for a variety of reasons. The Secretary has asked to pull together a group of health policy staff across the agency and including the MIA as well, to look at what could be done. Of course, the Medicare Advantage program is a federal program, and the ability to for the state to shape this in any significant way is pretty limited, but the concerns of some of the Advantage plans are significant. And Secretary, along with Governor Hogan, wants to try to do the best they can to stabilize this important marketplace as we move through the total cost of care model. In addition to that, I also wanted to alert the commission that HSCRC has informed us that a key feature of what we do together, that is administer the trauma fund, has gotten some inquiries from them, from hospitals recently, concerns about the adequacy of what are called standby payments to trauma physicians that agree to arrive at a hospital within 30 minutes. This standby formula or on-call formula is actually what I'm referring to. The on-call formula is especially relevant to trauma level 2 and level 3 trauma centers. Those are trauma centers with lower capacity than, say, shock trauma. And HSCRC has suggested that we work together on trying to identify potential solutions, probably meaning additional funding for these on-call stipends that are paid through the trauma fund. Some of you have heard me raise some concerns about the shift in trauma fund payments from a blend of some of it's paid for uncompensated care, some for Medicaid underpayments, and some for on-call payments over the last 4 or 5 years. The bulk of payments are already made now for on-call, and they're important stabilization payments. But should this go forward, it would involve a significant increase in funding that would be needed to keep the trauma fund going. Nothing is planned for this session of the legislature, but we would anticipate trying to convene a work group to identify that and the challenges that some of the level 2 and level 3 trauma centers report they're facing. And finally, just as a point to note is that we have begun using the Maryland Public Television Consulting Group to assist us in rolling out information on our Maryland Quality Reporting website. We are seeing some upticks in visits to that site since the bots began rolling out on the major news cable channels, CNN, MSNBC, Fox in particular, as well as some of the local stations. And we'll be providing over the next month, either April or May, to tell you what's really happening. We are seeing visits. We don't know how much people are drilling into the site, but it definitely does seem as though we're getting some traction through this. So really excited to hear that. And the fact is, there are some moves.
Following me around for a reason?
Once again, if we could ask people to please mute your computers or phones.
Maura, I think your line is open.
So we'll brief you on our progress with that. We are investing considerable commission funds in our various information gathering and dissemination purposes. and we recognize we want to use those wisely. I'll stop here with any questions.
I have a question, I think it's probably for Ken, it's about the all payer claims database data. I was looking at the report and, it says so far 26% of payers have the data submitted for last year. They've gone through all the checks. 65% of the payer data submissions are submitted, but in the process of being verified, and 9% haven't, or three payers apparently haven't submitted anything. And it looked to me like it seems at this point in the quarter, it's a lot, that 65% and part of being checked. I was just wondering if with the new portal in place, if there were any learnings we had, especially as to how long it's taking for payers to submit it and how long how the checking is going and how that would impact going to monthly. What's the prognostication, how that's going?
Well, I would say that it's going very well. This is the first time we have a new system within a submission period, and the payers have really responded very well. So we are really optimistic in the collection in this new environment. Some payers had some extension, getting used to the new environment, but the on-point data review is very comprehensive, and working with the new environment, I think we are doing very well. We're not too worried about the fourth quarter so much. We ask payers that for those who have extension, we want to know if that extension will affect the first quarter of 2022, because that will complete the 2021 since the first quarter of 2022 is the runoff of 2021. But we are very optimistic, and I think the payers have responded very well.
Good, in the portal so far, feedback from the payers, that's an improvement from everything.
And one thing to note, that in this new submission process, we giving payers two options. The old option where you go to the portal and submit these files one by one, or you could take advantage of the SFTP submission where you actually could submit the files. I think the very large payers, that would be very beneficial to them, to really streamline their submission process.
Is that a choice they have today? And
Yes, they have the process. Yes.
what would you say, how many payers have been using that?
Well, I would say the national payers who had prior onboarding with OnPoint are using it right now. But like our local payer like CareFirst, they still that they would actually use it probably in the second quarter, but on the first quarter. But for now, since CareFirst is the largest payer, they just want to use the current format, and they are doing very well.
Great, thank you.
Just on this bulk submission or bulk load, that was initiated by Cigna and United. Is that correct?
That is correct. Yes, Cigna has been lobbying this for the past 2 years, and we told them that well, we are not going to entertain a change right now since we are going out to it soon. So they are very happy about this the SFTP process.
Other questions for the executive director? Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform me. For commissioners who are participating remotely who wish to recuse, you should remain silent, turn off your camera. Commissioners in room 100 who are recused should move to a small conference room should that occur. The first action today is a request by Secretary Schrader that the commission extend the emergency CON previously issued by the executive director and approved by the commission that increased hospital bed capacity. Secretary is requesting that these ECONs, which are scheduled to be automatically terminate on April 30th, be extended until April 30, 2023. Paul Parker, Director of Healthcare Facilities Planning and Development, will brief the commission on this request. Paul.
Chairman, members of the commission. So we have issued a number of emergency CONs, primarily to hospitals, to expand their bed capacity temporarily in anticipation of surges in demand for hospital beds during the COVID pandemic. As noted, those are currently set to expire at the end of April of this year. And 2 days ago, the Secretary of Health asked that we extend these emergency CONs for an additional year until April 30th, 2023. We have guidance in place that we will be looking to modify in response to this, that will instruct hospitals on what they need to do if they intend to convert their emergency approvals into a permanent addition of bed capacity, and that would involve, of course, getting a certificate of need. I think what we have here from our executive director is a recommendation today to accede to the secretary's request and approve extension of our existing emergency CONs through April 30th of 2023. But as outlined in Ben's memo, this is actually kind of a two-parter. So he is requesting today that you approve what the secretary is asking for. But what we intend to do between now and the April, the April commission meeting is actually go back and review with all of the hospitals that received those emergency CONs, what their history has been in terms of activating this emergency authority. We did survey facilities at one point during the last 2 years. This was in the fall of 2020. And we actually had 2 surges at that point in time. And a number of hospitals had gotten through those surges without activating the emergency authority that they were given with these CONs. We want to update our information on how these emergency CONs have been used by the hospitals. We anticipate that we will learn that some of them really have never been activated during the entire period since they were approved. And in that case, with that information, we would intend to come back in April to let you know exactly, what the status of those emergency CONs are, and would be looking to, and Ben will be actually extending the CONs for those who have used them and want the extension. But for those who have not used them and they don't want an extension, we would not ask you to confirm those at the April meeting, but at the April meeting, we'll confirm what Ben has done in the next few weeks as far as actually extending the emergency CON. So we would anticipate that after the April meeting, we will have extensions in place and we'll issue updated guidance on that, but we will not be extending all of them.
So just a couple clarifying points. So I spoke with the secretary about this yesterday. The concern, as noted in his memo, is that there's a risk of additional variants cropping up over the course of the next year. We want to be able to respond as a healthcare system expeditiously to those variants. Following the news today, the BA2 variant, I think, is growing in Europe at this point. The incidence of new cases in the state of Maryland right now is 4 per 100,000 per day. The incidence across the United States is about 9. In the UK, in the EU overall, it's 125. And within Austria, it's 475. And those numbers are up 30% in the past week. So while we hope that doesn't happen here, hope's not a strategy. and maintaining some level of flexibility and capacity makes sense. We believe that up to 2/3 of the emergency CONs that we issued have not been acted upon. Is that accurate potentially?
I think that's probably pretty close to what we found the last time we surveyed, yes.
And we don't want to leave that unactivated capacity out there in an essentially unregulated capacity. That if people haven't needed to expand to this point, the likelihood that they'll need to expand without enough time to notify us again in the context of a new state of emergency seems to be more limited. And getting our arms around this a little bit and culling it down to the 1/3 that have actually been activated. And then after we get that data cleared up, extending those CONs for another year, ECONs for another year, important ECONs, not CONs, for another year seems to be prudent. So that's the proposal that's on the table right now. Commissioner Jensen.
First of all, thanks for the background. Thanks for the report. And I agree that the idea of having the beds available to respond to a surge is an appropriate thing for us to be thinking about and doing. One thing I do have a question about though, is just, could you walk us through sort of roughly what the financial implications of this might be through the budget process, through the rate setting process?
The emergency CONs were issued with fairly minimal information. But one of the things we did request as part of those requests for emergency CONs was an estimate of the cost of implementing those projects. Most of them were relatively modest. We did have a few projects that had substantial capital cost. So those costs, to the extent that they occurred, and they didn't occur in all cases, the hospitals, like I said, did not implement the emergency CONs. And so they just kind of had the status of contingency plans that the hospital could implement if needed. Those costs have already been incurred in 2020 or possibly in 2021. So the only cost implications, I'm not even sure if it's a direct implication of this, but to the extent that you have demand at a hospital and you're using emergency CON bed capacity to service that demand, this will be like any other increase in demand for your services. It will, you'll incur expenses related to that, and you'll also have revenue. And to the extent that that changes your status vis-a-vis your gross budget revenue figure for that year, which is a target revenue figure, you may have to get some adjustments in your GBR. Adjustments in GBRs have become routine since they've implemented that new payment model. So,
well, you're talking about adjustments in the cap in the spend in any 1 year, but no adjustment in the total GBR. So there were no adjustments to GBR for the bed capacity that we added.
That's really my question. The GBRs were not adjusted, and then correct me if I'm wrong, any adjustments in the GBRs would be in the future based on beds that were actually used at some point.
Yeah, to the extent that you show market share adjustment.
Right.
So, and that's in accordance with the old policy. I think the question is, when you have the additional bed capacity, your ability to mitigate fluctuations in volume associated with the pandemic becomes a little bit better, and therefore your ability to get your spend in within the year that it's designated, and not have to roll the spend into the following year. Is greater.
All of which makes sense. I just,
So, Paul, I'm hearing three sort of buckets of costs. And it would be like capital costs to set up, like, right, you first have to use the bed capacity by setting up the beds. And I guess there's the cost of keeping the beds ready to go, even if you haven't used it. So somebody that already used their CON may still be maintaining some beds in case they need to reactivate them. And then there's the other cost. I don't know if there's anything in this category. Is there any evidence that because of the emergency CON, that these additional beds are using for non-COVID related services? Like, has anybody expanded their use of hospital beds for other things because they have more beds? Putting aside,
Yeah,
I understand the
problem
budget.
seems to be in the other direction.
Yeah, I
That's just
understand the
sitting here.
budget discussion. I just, as the facts on the ground, I'm wondering if that's actually happening or you're
I
expecting.
would like to if they had the nurses.
Yeah, exactly.
Yeah.
That's the challenge is staffing beds. It's not having bed capacity, it's staffing them, and that's the rate limiting step.
Right, right. And look, and it makes sense. So if we were analyzing this long-term, I think we approve this, right? But analyzing long-term, if you're trying to develop a model for the next pandemic, how big should we go and things like that, I guess we would want to look at those costs versus the usage and what happened.
Yes, and actually, there is an effort underway to do that. The secretary has convened a group that is tasked with advising the department on how to have a plan in place for handling surges in demand for hospital beds in the future. And I recently joined that group, and we've had meetings so far where we're really trying to understand what happened in the last 2 years. Where did we end up in individual hospitals and in regions in terms of having enough bed capacity in place to deal with the surges? We're looking very closely at the issue of intensive care unit bed capacity and how to flex that when you have a pandemic of this type that will put heavy demands on intensive care units. And I think our initial goal is by July to have at least a preliminary plan in place. So we are going to be asking those kind of questions. What makes sense in terms of cost, in terms of having a readiness that we didn't have pre-pandemic to kind of quickly surge capacity at each individual hospital, but also in regions where we realize that we have to have some very specific plans because of what occurred during the surges we've had in the last 2 years. And what makes the most sense in terms of trying to have that surge capacity really occur in existing physical plants as much as possible. And clearly a charge to the committee to look at, work group to look at, is the cost of the alternative care sites that were set up. 3, 2 of them were hospital facilities that had recently been either replaced with FMFs or with replacement hospitals, but they were still intact. That was the hospital in Tacoma Park, the former Washington Adventist Hospital, and Laurel Regional Medical Center, which has converted to a freestanding medical facility site. And then the Baltimore Convention Center was the third one. So one of the things we're charged with is really looking at, whether that strategy for dealing with surges made sense, and in terms of its cost and the way it required a shifting of staff from the hospital campuses themselves to these care sites.
I think that makes sense because for me, like looking at our role as a commission, we're not going to keep pandemic costs down by niggling on CONs, right? We're not going to be like, not an emergency for you. We need a rubric of understanding how an efficient response is. Right? Because I'm not going to be comfortable going, this hospital doesn't treat these people. It's just not that bad. Like it doesn't seem like something I would be able.
Mr. Gordon?
Mr. Chairman, I just asked a process question. You said you talked with the secretary. And he's asked us today to approve all of these and just extend everything for another year.
Right.
Is there going to be any issue, as Paul talked about, if we come back next month and want to take away 2 or 3 of these right now because they're not really being used?
We're not talking 2 or 3, we're talking 2/3 of them potentially.
Well,
But
I don't care whether it's one or all, because today we're
No,
approving.
he was fine. He was not aware that 2/3 of them had been unused. He agreed completely with the concept of the.
And we're not going to run to a hospital issue with people saying, wait a minute, you've just approved these for a whole year. Now, a month later, you're trying to take away.
No, we're not approving it for a whole year.
Yes, I thought.
No, we're just approving for the whole year. We're going
Continue for another year.
only those that are activated. Only those that are activated, not the ones that are not active.
Oh, so the motion is going to be only for the ones that have been
That's
activated,
correct.
not for.
But
And you'll come back.
we're gonna come back
sometime
next
tell us.
month, before the end of the month, when the current expiration date is, with an inventory of what's what. We don't have the inventory.
No, I understand.
Yeah.
Okay, so I
And that's
misunderstood.
consistent.
I
And
thought we were
the
just
secretary's
blanket
comfortable
going
with
to,
that.
he wanted to just approve them for another year.
He but he didn't realize at the time they wrote the letter
Okay, so
that
the,
that exists.
so the letter's not what we're.
That's correct. We're not voting on the letter. We're voting on, today, we're gonna vote on the concept of what we're gonna do. Next month, we'll vote on the actual roster.
Okay.
So we don't know how many hospitals will fall into these categories yet.
No, I understand.
We need to do the.
And the secretary was not necessarily aware that 2/3 were
Not. It was, the secretary was concerned that and rightly so,
Right.
that these were about to expire. And we're starting to get signal that we may be looking at another, another variant or, a variant of a variant, the variant of the Omicron with a potential another wave. And in that context, shutting down the capacity that we have. So that would take away Laurel 3, 4, 5, Tacoma Park, the convention center, which is already shut down. But it would take away the capacity for all those things right away and force us back into another state of emergency. We might not need a full state of emergency in order to reactivate those things.
So just to add a little cloth on the CONs we approved, some were very desperate at the time.
Once again, the people could please check. Please mute your phones. Your phones.
So,
Folks mute everybody on the panel.
can our staff just inquire with Levon if he can mute everyone except for the commissioners that are attending? So it was using in military terms, desperate ground people were on in the early days. So things like cafeterias, conference rooms were approved for emergency CONs. As far as we know, they were never operationalized. So those are going to be easy calls. In thinking about this process, we're going to make direct inquiries to the hospitals. And even if there may be an instance or two where someone may say, we haven't used it, but we think this is near ready to be put into operation, and we would come back with that information to say, give that exception. The other point that the commission should keep in mind is that in the course of those early days of the pandemic, hospitals were also encouraged to get temporarily licenses for physical bed space they had, but wasn't covered under their current license. And I believe about 1,500 beds were temporarily relicensed by OHCQ during that period. And some of that may continue to be used. We don't actually know that. In comparison, about 1,100 beds were approved through the ECON process. So their first stage that I think many systems probably went through is to bring their physical space that was not licensed back into temporary licensure to use that, and then jump to the expansion through the ECON. But clearly, conference rooms, MOBs adjacent to the hospital, and such desperate measures were not needed in Maryland, fortunately. And lastly, and Sarah, if you have a comment, we still would believe that under the Secretary's existing authority, we could issue a new emergency CON tomorrow. If someone came forward, demonstrated a need. So those that didn't use their capacity, didn't think they needed capacity, but a month or two later come forward, as long as the Secretary is invoking this request through April 2023, we think we could approve a new emergency CON if the circumstances required.
Ben, this is
All right.
Commissioner Bandari. I just want to clarify, those FEMA beds which are in the parking lot or those are in tents, that this CRA does not apply to that. Is that correct? Those are completely different matter.
You're asking about the additional bed capacity that's within the mobile facilities?
Many hospitals has these, tents outside on the parking lots.
Yeah.
Or outside the
Well,
building of the hospital.
that is part of
That's a
this.
FEMA.
Yes.
Yes.
It does not
Yeah,
apply
there's
to.
just, as long as there are beds in them, then they're covered by this. The structures, I think, supplied by FEMA.
I could add.
Some of our emergency CONs were of that nature.
Right.
And it is our understanding that most of the FEMA tents are not used for housing patients, for beds, are used for testing, for vaccine sites, et cetera, inpatient services. So
That is correct.
they wouldn't be affected by this. But my understanding is most hospitals want those tents, prefer to have those tents down.
Yeah, I think there's variability around that. There's nothing stopping them from taking them down. Our CONs don't force people to keep things open. All right. There's a motion on, do I have a motion to accept the plan to do an inventory this month with a plan on approving for continuation for 1 year, those CONs that have been activated or in the process of being activated?
Question, are we going to include the show cause provision for non-activated econ that someone didn't come forward and say they wanted to activate?
Yes, yeah, or plan to have activated.
Yes.
So that was the intent of that language.
So moved.
Commissioner Gordon, second, Commissioner Jensen. Any further discussion? All in favor?
Aye.
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 Any opposed? All right. Motion to direct the executive director to inventory existing ECONs and report back with specific plans. Agenda item number 4. Certificate of need application filed by Hija Incorporated to establish a 50-bed Track 1 intermediate care facility for adults in Baltimore County, Maryland. The proposed intermediate care facility will provide level 3.7 medically monitored inpatient services and withdrawal management care. Jean Marie Gall, CON analyst, will present the staff recommendation.
Good afternoon, Chairman Pollack and Commissioners. Hija Detox Inc., or Hija, is proposing a 50-bed Track 1 intermediate care facility, or ICF, offering American Society of Addiction Medicine level 3.7 medically monitored inpatient services and withdrawal management for adults. A Track 1 ICF primarily serves individuals who can pay privately for care. Hija is a for-profit company owned by Robbie Stempler. Since 2016, he has also been the CEO and owner of Malibu Detox in California, which at the time of the application operated 3 separate locations, all of which were Joint Commission certified. Since the time of the application, the locations have grown from 3 to 5. The main goal of this project is to improve access to alcohol and drug treatment withdrawal management services in the central planning region of Maryland. The applicant will be working with Middle River Ventures, real estate developers that will absorb all of the costs related to the land and construction of the facility. The applicant's 12-year lease will include 7.27 acres with a 29,308 square foot facility. The total project cost is over $11 million. However, the applicant's portion of the total cost for this project is $482,840. It will be funded with a business loan. Regarding need, although the bed need methodology for ICFs is considered outdated due to the fact that existing ICFs are able to add beds to their inventory without CON review, staff still calculated a bed need of 23 to 65 for the target year of 2027 in the central planning region. Since the time of the bed need methodology's creation, the rise of addiction has been evidenced by the creation of the governor's heroin and opioid emergency task force in 2015. Other evidence of need was documented by showing long wait times for treatment, as well as the continual rise of unintentional intoxication deaths in Maryland. There is also research being conducted on the impact of COVID-19 pandemic on drug and alcohol addiction that shows this population is at an increased risk of negative outcomes from the disease. Regarding viability, Mr. Stempler provided documentation via an independent certified accountant of his ability to manage a successful business as demonstrated by the financial performance of his similar business venture, Malibu Detox. The accountant also verified Hygia's ability to meet terms of the business loan for the project. Regarding impact, due to unmet need, there is little anticipated negative impact on other existing Maryland ICF providers, all of which are over 20 miles away from the proposed project location. The applicant has also met the relevant state health plan standards. However, staff is proposing the following 3 conditions. 1, Hygia shall submit to the commission documentation of the provision of a minimum of 15% of patient days of care of indigent or gray area patients as a percentage of total days from the project's inception and continuing for 5 years thereafter. 2, Hygia must receive accreditation by CARF, the Commission on the Accreditation of Rehabilitation Services prior to first use. And 3, Hygia shall provide written transfer and referral agreements with the Behavioral Health Administration prior to first use. In conclusion, staff recommends that the commission approve the project. Representatives from Hygia are in attendance at the commission meeting today. Robbie Stempler, CEO of Hygia, Stacy Fruling, COO of Hygia, Robert Rajewski, Project Manager of Hygia, Tom Dame and Ella Aiken, Counsel, Gallagher, Avelis, and Jones. This concludes my report. Thank you.
Thank you, Jean Marie. Do we have a motion to approve the certificate of need to establish an alcohol and drug abuse intermediate care facility by Hygia Detox Inc.?
So moved.
Commissioner Gordon.
O'Connor.
Commissioner O'Connor, second, Commissioner Jensen. All right, discussion.
I have a question. It looks like the projections are 23 to 65, and this is a 50-bed facility. I was wondering, is this a normal size facility, an average size, unusually large, designed to exactly match the projected need for 2027? How did we get to the 50 beds for the facility?
It wasn't designed, I don't believe, to match those projections. In fact, when the application came in, the applicant's projections were actually much higher than that. And this is the commission's, we redo the calculation. Just a coincidence, I think.
I have a question. I see
The
one.
project cost is going to be 11 million. Where the rest of the cost, money is going to come? Because the applicant is providing only $482,840. Where the rest of the money will be coming?
Right. So the rest, they're working with Middle River Ventures, and they're a real estate developer. And they're going to provide the additional funds for the land and for the building of the facility. And then the applicant will lease from them, and they're going to be entering into a 12-year lease.
Thank you.
I have a question regarding the staff recommendations, Mr. Chair.
Commissioner Brumback.
The Hygia said that they would do the reports, they offered to do the reports starting with the commencement of operations, while the staff's recommendation is from the project's inception. Can you please explain the reasoning behind that? Because you would think that project's inception, meaning construction, would take a little time. and during the construction, there will not be any patient days.
I'm having trouble hearing the question. Could you repeat your question? I'm sorry.
Sure, no problem. So in the staff report and recommendations, page 10, Hygieia offered that they will do the reports starting with commencement of operations, while the staff recommended from the project's inception. I don't know how long the construction of a 29,000 square feet facility takes, but you would think that that would be a while. And during construction, there will not be any patient days. So can you explain the reasoning behind why staff would like to see that reporting beginning with the project's inception instead of commencement of operations?
Oh, okay, you're sort of saying it the word choice. So what we're going to be looking for with that condition is that once they open, once the facility opens right before it opens, prior to first use, they're going to be reporting to the commission the percent of facility days for the indigent and gray area patients, but it won't be until the facility opens and they have patients there.
So that should be commencement of operations and not inception of the project, correct?
Right, I see. It was a confusing word choice.
There's also, is there a desire for them to have progress reports on the construction during that time?
Yeah, that's basically also is a question as to what's the reasoning behind.
They will also be reporting as part of their quarterly reports that they submit to the commission as the construction goes on. They'll be giving us progress reports during that time as well.
Commissioner Johnson.
Yeah, I noticed in the first condition, there is a condition to show that there's at least 15% of patient days go to indigent gray area patients. And we do a lot of, we have a lot of discussion here about disparities in access to healthcare. And I'm wondering if there was any discussion or thought about including in that condition, expanding indigent to include some of the other categories that we discussed when we're talking about disparities in healthcare.
I don't believe that we made a consideration for that as part of that condition.
I'm wondering if that wouldn't be something appropriate in light of just sort of the publicly available information that suggests disparities in access to healthcare facilities are consistent throughout rehabs and in all areas of healthcare. If that wouldn't be something that would be worth at least thinking about.
Mr. Chairman, this is Tom Dame, counsel for Hygieia. May I respond to that point?
Please.
Thank you. I think it's a good point, Commissioner. However, right now, your state health plan chapter does not address that. The state health plan chapter addresses indigent and gray area patients. So I think the proper or more appropriate way to approach that would be to look into perhaps amending the state health plan chapter in the future rather than imposing a condition on a particular applicant, in this case, Hygieia. But I think it's certainly a worthwhile endeavor. Just probably shouldn't be done in the context of a single case, but should be done through the policy that the state health plan chapter represents.
I think the point is well taken. I think the response was intended to address the state health plan chapter. The concept of needing to address the disparities in greater depth than the state health plan chapter currently anticipates is one that we need to consider, I think, separate from this action.
And then can we consider putting that on an agenda?
We, the state health plan, the revision of the state health plan chapter in this context is, I don't know, where that's recently been done. Is that correct?
Not
Paul? Not on this one?
In the latest update of priorities for state health plan development, this was identified as a high priority. And so try to start working on it this year. Look for an update in 2022. We put it off because we were trying to
Fair.
regulate this category of
Fair
facilities.
enough, but just to be clear, that language is common to many of the state health plan chapters. Is that correct?
Yeah, this condition here is very specific to what the state health plan requires for a track one facility that doesn't participate in Medicaid. So
I just think it's not a particularly great look. If we have this problem with drug abuse. We're saying we don't have enough beds to treat people. We talk about wanting to make sure that there is access for everybody. And then in this context, we say, well, we can't do it in the context of this certificate of need because it's not part of this plan. You know, we're kind of talking about one thing, but not getting to it for reasons that are not particularly satisfying. So I understand in the context of this certificate of need, we're there, but certainly seems to me to be important.
Yeah, no, as we update the state health plan chapter, and this is high priority right now.
Right.
Then that is something that should definitely be considered. Absolutely.
And when this standard was written years ago, we felt that the appropriate way to place a requirement on serving low-income individuals was to define this indigent and gray area population based on household income. But certainly we can look at expanding.
But we know that household income isn't the only marker of equity.
Right.
Those are two separate issues.
Yeah. And what I would say to Council Dame, it's not required, and we're not going to put it, probably not going to put it into the conditions for this certificate of need. I would encourage his client to consider that in their operations.
Thank you for that.
To be clear, these are requirements that say you meet a certain threshold of providing services to people, right? A certain percentage of your services go to people who can't pay. Those other markers, age, race, ethnicity, we're not going to put a standard in saying that a certain percentage of your participants must be a certain race. That would just be wildly inappropriate. So to the extent we're talking about collection of data, I think it's a good idea, but it's fundamentally different from this idea of provide a certain amount of care to people who otherwise couldn't pay.
But it doesn't mean we can't mandate that programs be in place to consider health equity.
We can find a way to do it. It doesn't have to be measured exactly the same way, but we can find a way to do
What I'm
it. And we
saying
should.
is, we've got to approach that from a completely different angle from just putting a standard. Like it's a whole different analysis that we should sort of go from square one. It's not
We
easy.
could put a
to
standard in place. It could just be a different standard than saying 15% has to be, this and 20% has to be.
It's going to be a fundamentally different standard that requires careful thought.
Yeah,
And we should pursue that thought, is my point.
the need to consider health equity in the development of the chapter is noted in.
One of the fun things about raising a point like this is it often sounds as if the person who's raising it is not accused of being against health equity.
No.
Is not doing it the right way.
There's no intention to think about that. We see the minutia of how we do it is not something we're gonna get to today.
No, but what I mean is it's not a simple matter just added to this, because this is a very different and easy standard. If they can't pay, they should have a certain amount.
My only point here, first of all, there's no implication that you're not in favor of health equity intent. In fact, I'm certain that you are in favor of health equity based on our prior conversations. Second point, as soon as I heard that, it would require an amendment to the state health plan chapter, then I'm okay. We'll have the more nuanced discussion in that context and not here. And you rightly raised that.
And we may want to think of it as an element of planning that transcends particular chapter.
Can you please elaborate, what is the gray area? I understand indigenous, what is gray area population is? What does that include?
Those are households that have incomes above the Medicaid qualifying income. I believe it's
135% of FPL.
Were you able to hear that, Commissioner Bandari?
Thank you, yes.
Okay. All right. I have a motion and a second on the table. All in favor of approving the certificate needed to establish an alcoholism and drug abuse intermediate care facility by Hija Detox, signify by saying aye.
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 Any opposed or abstaining? The certificate of need is hereby approved. Thank you.
Mr. Chairman, I believe Robbie Stempler, founder and owner, would like to just say a word of thanks, if you may.
Mr. Stempler?
Yes, thank you, guys. I appreciate it. And I just want to, thank the commissioners and the commission staff for your time on the review. And, I'm confident in Hija Detox, our mission to help Marylanders with substance abuse and overcoming that, and look forward to providing these important services in the coming years. So thank you guys very much.
Thank you. Thank you for your work in bringing this facility to us.
My pleasure.
All right. On to agenda item number 5, professional services report. The Maryland Healthcare Commission is required in our statute to report annually on expenditures for privately insured professional services using the Maryland Medical Care Database, the MCDB. The report, Payments for Professional Services in Maryland, examines variations in in-network payment rates for professional services in Maryland and provides a comparison of private payment rates to Medicare and Medicaid payment rates for the same set of services. Estimating what Medicare and Medicaid paid for the same set of services is one method of judging the adequacy of private payer fee schedules relative to the public payer sector. The report also examines findings from several national studies that compare private payer fee levels across all states. Benchmarking Maryland fee levels to other states is relevant as payment levels are key factors when Maryland practices and health systems recruit or try to retain physicians and other healthcare practitioners. Shankar Mehta, Chief of Cost and Quality in the Center for Analysis and Information Systems, will present the results of the study. Shankar, please proceed.
Good afternoon, Mr. Chairman and Commissioners. Thank you for sharing the purpose of this presentation. I am excited to report the 2020 annual update on variations in payment rates for in-network professional service among private health insurance carriers on behalf of my center. Next slide, please. All right. So for this analysis, we have used MCDB data from 2018 through 2020. The study population includes members with age under 65 years. This includes only in-network service payments, which comprises about 99% of total RVUs. We excluded Federal Employee Health Benefit Program data from our analysis due to the reporting restriction imposed by the Office of Personnel Management on payers. To get everyone on the same page, the large private payers in this report include CareFirst and United Healthcare data. They both combined contributed to approximately 87% of total spending reported in this analysis. Next slide, please.
I think he's coming. Paige Turner is coming.
Okay. All right. Thank you. All right. So payment rates for professional services are basically the payments per relative value unit at the same service level. RVUs reflect the resources associated with each service, where each service has 3 components. 1, the work component. 2nd, the practice expense component. And the 3rd, related to obtaining the medical malpractice insurance for a service. So for this report, we used RVUs from 2020, 2019, and 2018 Medicare physician fee schedule, which provides information for more than 10,000 physician services. By calculating payment per RVU, we are able to compare resource utilization across different types of services, such as surgeries, imaging, and testing. This also allows us to compare payment across payer types, across specialties, and cross-market comparison. Next slide, please. All right. So the payment rate for all types of private payers combined was $40.11 in 2020 compared to $39.57 in 2019. This is a marginal increase of about 1.4%. In comparison, the payment rates from 2018 and 2019 decreased by about 0.3%. The payment per RVU was lower among large payers for all 3 years. Large payers paid $39.40 per RVU, which is about 90% to that of other payers. This is comparable to previous year's trends. When you look at the year-over-year trend, the payment rate was lower among large payers compared to other payers from 2018 to 2019. This result contrasts with the change from 2019 to 2020 because of the lower payment in 2019 within the large payers. As noted in previous year's report, large payers are able to negotiate better prices, which explains the less payment rates in large payers compared to other payers. Let us now look at the impact of the geographical region. Next slide, please.
Next one. What is this one? I don't know.
Is it a duplicate of the same slide, Shankar? Because I did change.
No, this is Maryland regions on payers. So this is the next slide.
Yeah, this is the next slide. Yeah,
Go back.
previous one, allow on, please. Yeah.
That is.
Let's go back to the one.
back.
One had up.
This was the top one.
Back one.
The previous one, please. Yeah,
Here you go.
yeah, this one.
This one?
Yeah,
Oh,
yeah, that's right.
yes.
Yeah. All right. So, okay. So the payment rates in Maryland varied by region based on the various factors, including but not limited to the resource cost and payer mix in each area. So participating providers in locations with higher resource costs tend to receive higher rates from payers because carriers account for the difference in resource costs associated with the provider's geographic location. The geographic practice cost indices for the DC, Maryland, and Virginia suburbs region is the highest compared to any other geographic area in Maryland. Hence, providers located in DC metro area received a higher average payment rate than other providers located in Maryland, regardless of the payer market share from 2018 to 2020. Next, we will look at the private payers versus Medicare payment rates comparison. Next slide, please. All right. In 2020, private payers paid about 3% more than that of Medicare payment rates. In 2019, it was 2% more compared to Medicaid rates. So to understand how Maryland physician payment rate compare nationally, we compared our methodology with a similar methodology adopted by the Healthcare Cost Institute to calculate payment rates. Using a sample of nearly 210 million claims for employer-sponsored insurance individuals in 2017, HCCI measured the average commercial prices paid for 500 most commonly provided services in physician setting across 271 metro areas and across 48 states and Washington, D.C. They found that private physician payment rates were on average 122% of Medicare rates nationally in 2017. As shown in figure, the average private rates varied dramatically across the states from below the Medicare rates in Alabama to nearly twice the Medicare rates in Wisconsin. Maryland showed an average private rate of 104%, which is comparable to the percentage what we have found in our analysis. So if you want to look into the much of the variation in the professional payment is due to the physicians and insurers' market power, type of physician services used in the analysis, and the payment components included in the calculation. And when we break this down by large versus other payers, large payers paid just about 1% more, whereas other payers paid 11% more in 2020. The difference is mainly because of the mix of services provided by those payers. So now let's look at private versus Medicaid rates. Next slide, please. So private payers paid 21% more compared to the Medicaid fee schedule for similar services. This is comparable with previous year's observations. Again, when we break this by large and other payers paid 30% more, whereas large payers paid 19% more. Next slide, please. Okay, so the key takeaway from this year's report are the payments per RVU for all payers increased about 1.4% in 2020 compared to 2019. In comparison, we observed 0.3% decrease from 2018 through 2019. The private payers rate for 2020 were about 103% of Medicare and about 121% of Medicaid. Compared to a year ago, our private payments were about 102% and 118% of Medicare and Medicaid rates, respectively. Private payment rates in 2020 varied by geographic region in Maryland, with the highest rates in DC metro area. This concludes my presentation, and I just want to thank Ben for sharing the benchmark report with us, which really helped us to compare the percentage that we were seeing in our report to and what was reported in the HCCI report. Thank you.
So, Shankar, thank you for that report. It's always eye-opening to see where we sit compared to the rest of the country. When these numbers reflect fee-for-service payments only, correct? They do not include
That's
things
right.
like MPPCP or PCMH. So this may not be a complete reflection of the market that the physicians experience in the state. And to the extent that we may have a disproportionately high component of payments in those incentive-based, value-based care programs in Maryland relative to other states, we may be underestimating the physician payment models somewhat. Is that accurate?
That is right. That is right. Because in our analysis, it is very hard to find out that either it is whether the physician were paid any additional bonus or if they were penalized for certain services based on the contract. So this does not include that component.
I bring that up because as a surgeon in Maryland, I'm inclined to look at this and walk away with, we're in the bottom 4 in the country. And trust me, I'm still walking away with that message. I got that. But I just want to reflect that that it's a little, the calculus is a little bit more complicated.
And it changes over time because there are more programs now than there were.
It does. The bottom 4 piece doesn't seem to change much over time, though. The Commissioner, Ben, I think was first.
Yeah, so that's true. Most of if we looked at value-based programs across the country and based on recent testimony from national payers, Maryland's behind many states in the introduction of these value-based, capitated, episode-based programs. So I think probably the percent of reimbursement that's fee for service in Maryland is probably higher than many states, particularly as you move further west. And secondly, the premier value-based program that has existed, the Care First PCMH program, actually does roll their value-based payments into their fee-for-service fee schedules, so it's probably captured. But you are correct in one way, but it may be actually make the situation worse. Is that Medicare does have value-based programs that we are not able to capture. So the percentage of Medicare payment that is value-based, the target is increasingly being raised. And so their payments are probably, of all the payments we have here, Medicare's might be underrepresented to the greatest degree possible.
But you're not making me feel better.
Yeah, I don't want to make, but I mean, we do have to also, in the MedPAC report 2015, or they came out on the 15th yesterday. They did judge the Medicare physician fee schedule as adequate to cover costs for a reasonably efficient practice. That's Medicare, and it doesn't take into account that it's, of course, it's one payment stream for most physicians. But MedPAC does that assessment every year, and they come up with the same answer every year. Kind of not surprising, but it's good to know.
Commissioner Jensen.
So we are comparing here unregulated services, correct?
We're comparing Part B services, just physician services.
Right, so no HSCRC regulated.
No HSCRC regulated services. Well, they could be physician services delivered in an HSCRC regulated environment, but they're only physician services.
But when we're talking about comparisons here, we're talking about services that are compensated outside of the global budgets.
Yes, everything is outside of global budget.
And this is Commissioner Bandari. I have two questions. One is, do we know how many doctors are participating in those value-based programs? And secondly, I think as Dr. Pollack mentioned, he's a surgeon, I'm a specialist. We don't have any value-based program. So I think I agree with Dr. Pollack. It would be very difficult to attract new physicians to come to Maryland. It's, even Virginia has, for many specialists, 10 to 50% more, better compensation compared to the Maryland reimbursement from the insurance companies. It makes me really concerned.
Oh, so just to make a comment to that, Commissioner Bandari, your comments are from the perspective of a private practice physician model.
Correct.
And I
Yes,
think
most of the
point-
physicians, primary care or most of the specialists are, I think, still private practice.
I'm
Probably.
not sure that's true anymore. And I think the
So
challenge.
most of the, now they're joining hospitals. That may be
I think the challenge is that this type, the reality that is reflected in this report is why it's becoming harder and harder for private practices to maintain sustainability. You can't, we're looking at $40 an RVU, and I can tell you, I can't hire physicians for $40 an RVU. And that's the entire payment. That's the whole thing all in at $40 an RVU. And that's in order to be competitive for recruitment with other states, to Commissioner Bandari's point, we have to pay more than that. In order to pay more than that, the dollars necessarily are getting diverted from the GBR to physicians to offset the losses, quote unquote, in the physician practices. And it impacts the cost of hospital care dramatically, but it also impacts the sustainability of the private practice model. They can't compete with it because they don't have GBR dollars to divert into it. So, Commissioner Jordan.
No, and just to pick up on that, as often happens, at least what I've seen, we do a lot of really great reports and we'll approve it. Okay. But the real question is, so what? Okay, so what, if you know you have an issue, do we, as a commission, have any role in making recommendations or helping to fix the issue? If everybody agrees it's an issue, some others may not agree, but this is a nice report, but so what?
Yeah.
Seriously, 2 years from now, we're gonna get another one and it's gonna be for those 2 years. And we're gonna say, so what again, I guess? What happens? Is there a proactive role that this commission could or should take with these kind of things?
So, I'll take a stab at this now. I'll ask Ben to think about a response, but this is information that needs to inform the HSCRC as they continue to develop the model in partnership with CMMI. This is, I think, information that CMMI needs to consider the reality of the cost shift that this necessarily creates. An understanding of it. I think if you ask me what's CMMI's lens on this, their lens on it is your total cost of care in Maryland is the problem, guys. It's not hospital costs. It's not everything else. It's figure out how to make the whole thing work. We're looking at one piece of it and saying the pie is being disrupted as a result. All of that's true. I think this informs that entire discussion importantly. I don't know that I could look at this and come up with a recommendation. I could come up with a recommendation to say to Care First, you guys don't pay us enough. And I think we should vote on that.
It'd be like squeeze the hospital. If you squeeze the hospital into the tube, you will increase the physician.
Right,
into the
right,
tube.
but I think
Okay with that.
look, I think this is an important piece of information for us to have, and to answer your questions, I don't know what to do with it next, to be honest. But I think it needs to inform all those other discussions. Ben, you have anything smarter than that?
No, I mean, I think that this information, unlike much information, does get gobbled up, particularly by the provider lobby, government relations folks, and is pretty well aerated, socialized in Annapolis. There was a bill which we discussed, which set payment floors for out-of-network behavioral health, which if you do that, you're also implicitly imposing elevated fee levels for in-network services as well. Do I think that's the best approach? Probably it's a solution, but a broader based approach on fee levels is probably better than trying to tinker with the out-of-network arrangements, which we all think, it's not good to have to use out-of-network providers generally because they're not properly submitting claims on behalf of patients. They're not subject to some of the value-based incentives that many payers are now realizing are valuable. But we do think that it percolates through the system. I don't think the commission should be recommending payment floors at this point, but we should be raising that as an issue in the context of what this means, and issues raised about recruitment. We are do okay for physicians, but as this becomes more better recognized, it's going to have an implication. And CMS has recently signaled that residency programs are going to be expanded. There are going to be new opportunities for expanding and diversifying the workforce that are going to have an impact on us, and we have to take that into account because what payment rates are does matter. I would point out that in the past we've tinkered with payment rates. I don't think it's had harmed payer networks all that much, but it's kind of clumsy way to do it. The last point I would make is that no one looked at the end of that tail. The state that's at the end of the tail is Wisconsin. And there you have a very high level of physician consolidation. And people like Dr. Pollack and others, may be reporting back to their masters, whoever they are, and say, we got, the more leverage, we need to consolidate, we need to absorb more practices, because in Wisconsin, the health systems have enormous amount of leverage, and that converts to payment rates that are about 180% of Medicare, as opposed to 110% here. So in fact, I think in some ways, provided some of the payer representatives complain about consolidation for 8 months of the year, and then do everything they can to encourage consolidation 4 months of the year during the legislative sessions. And payers really need to think constructively if we want an independent physician industry in the state. Maybe a little bit more generous payment rate for those that are delivering high quality care might be the best formula.
One thing to think about with this issue is, I had a toothpaste tube analogy. I think that's right. Like the payer committee, nobody wants to increase the total cost of toothpaste. The toothpaste tube, there's enough toothpaste, right? We don't want to have to pay more overall. So this report tells me that one part of the tube may have less paste in it than other parts of the toothpaste tubes in other states. If you just try to fix this and you ignore the fact that there's a big thing of paste over here in some other part and you don't address it at the same time, you just increase the total cost of care. And I think when you get to Annapolis, you have isolated bills. Let's pay this doctor more, or let's pay this a little less. And you wind up arguing one side's going, but healthcare costs are going to go up, and the other one's arguing, but this one thing is unpaid and it's not a comprehensive solution. And that's what I've seen go on.
Look, you're arguing for a total cost of care model, which is where we are.
And I would only suggest that, I like the analogy, but I think instead of a toothpaste tube, I would suggest one of those little balloons that the folks make, you know, that there's multiple, you can squeeze all sorts of different areas. There's not just two to squeeze, there's a bunch. But we haven't talked about pharmaceuticals very much.
Yeah, it's a sad story. Could I ask one question about the data here? Is it possible, I was looking at the chart on the categories, where you break down by the category of service, and it's on page 8 of the report, but it's not really about that. It's really, are we able to like look at the specialties for the submitting physicians? Because, you know, like, it would be instructive. The anesthesiologists sort of get pointed out because anesthesia is a category, right? But are you able to, we break the data down that show like oncology, internists, you know, primary care physicians, those sorts of different categories to see where some might be under the line and some might be over the line. Those differences, I think that might be an instructive analysis.
Definitely, Commissioner, we can drill the data to that level. In fact, we tried doing that as part of this report, but when we were trying to use the specialty categorization, what we used, and when we tried to join the commercial data to the Medicare, we had some mapping issues, and that is why we kind of put a stop on that. But for the future report, we are going to look more closely into that issue, that what we have, and maybe we'll have more experts from from in-house and maybe from our new vendor look at it and help us to address that. And if we are able to do that, then yeah, we can bring that reporting also. We can add that into the report in future. But short answer is yes, it can be done because we have the data elements in our data.
Thank you.
Do we know what is the reason imaging and tests are being paid more than E&M, evaluation and management? Because that's really bread and butter for most of the primary care physicians. That's what happening. Primary care physician has to see 30 to 40 patients a day to just pay their staff and rent and all those things. It's very hard. It's not easy, and patients are getting more and more complex. So it looks like if you are a radiologist or open an imaging place, that's better than being an internist. Or if you open a lab, that may be better than internist. They work very hard. So if you can look into that, what is the reason for paying certain imaging facility? They may be more technical part. That's testing is also more technical. So that means technical part is giving more reimbursement compared to a hard work done by a physician who is going to listen to the patient and make a proper diagnosis and management plan.
Surely, Commissioner, we can look into that aspect as well.
Thank you, Shankar. Agenda item number 6. Preserve Telehealth Access Act of 2021 study update. So the Preserve Telehealth Access Act of 2021 requires the commission to conduct a study on the impact of telehealth services as it relates to use of audio only and audio-visual technologies for somatic and behavioral health interventions. Mhcc and the study contractor Norc will examine claim data, conduct a provider survey focusing on providers' views of telehealth since the start of the pandemic, and convene consumer focus groups to gauge attitudes about telehealth. The consultant will also conduct a review of the numerous research studies on the use of telehealth since the onset of the pandemic. The findings will inform the development of recommendations on continuation of audio-only care and audiovisual coverage and payment levels relative to in-person care. David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery, will provide a review of the progress on the multifaceted study. David, the floor and the airways are yours.
Thank you, Dr. Pollack, and good afternoon, commissioners. It's great to see everyone, those in the room, and of course those on the webinar. So next slide, please. Levon, can we advance one slide? Thank you. As Dr. Pollack mentioned, MHCC is required by law to conduct a study on the impact of telehealth with the focus on audio-only and audiovisual technologies for somatic and behavioral health interventions. In June of 2021, MHCC released an emergency request for proposal. In September, an evaluation panel consisting of staff and external reviewers competitively selected the National Opinion Research Center, or NORC, at the University of Chicago. A final report is due to the Senate Finance Committee and House Health and Government Operations Committee by December 1st, 2022. Next slide, please. Okay. Included in the appendix sections of the slides is the complete list of study requirements in law. Some requirements that are notable, and I will point them out here, include the impact of telehealth on uptake rates among different communities and different patient populations, comparative effectiveness and efficiency of telehealth and in-person visits on the total cost of care and patient outcomes of care, the efficiency and effectiveness of telehealth and in-person visits, and barriers to care and levels of patient engagement that have been addressed by audio-only and audiovisual technology. Next slide, please. The study has several elements: a literature review that focuses on evidence of the effectiveness of telehealth and new and emerging trends. Findings will inform development of 6 briefing papers focused on utilization, integration of telehealth into new models, and the impact of disparities in access, care quality, and patient safety. Claims analysis using commercial and government claims from MHCC's all-payer database will occur to complete a comparison of cost and service utilizations for telehealth and in-person visits and uptake of telehealth before and after the public health emergency in the 4 regions noted at the bottom of your slide. Next slide, please. The study also includes a provider survey, which will inquire about using audio-only and audiovisual technology for the delivery of care in both rural and urban areas. Telephone interviews will be used to assess patient experience and perceptions related to access and use of audio-only and audiovisual technologies. 2 behavioral health focus groups are planned to gain insights from community-based mental health and substance use disorder providers about the delivery of mental health and substance abuse use disorder services. Next slide, please. So let's talk a little bit about where we are and the work that's been completed. We're picking up some background noise. Folks could
Please, again, if folks could mute your phones. Thank you.
Okay, thank you. NORC has screened nearly 3,000 abstracts. Oh, next slide, Ron. And so, as I mentioned, NORC has screened nearly 3,000 abstracts and has identified about 250 articles for review. This work will inform development of the 6 briefing papers. Next slide. Okay. A non-disclosure agreement between MHCC and NORC was recently executed. The APCD vendor, OnPoint, has established a secure multi-factor access authentication process for the 3 NORC researchers who will access the APCD. Next slide. A provider survey flyer was provided to around 20 healthcare associations for promoting with their members. The provider survey is targeted to close at the end of May. As of March 14th, which is week number 2 of the survey, nearly 158 providers have completed the survey. The goal is to collect at least 500 responses. Next slide, please. Consumer engagement activities began about 4 weeks ago and are targeted for completion around the end of March. Roughly 104 consumer interviews have been scheduled and 57 of them completed. Next slide, please. February, staff requested NORC add 2 additional behavioral health focus groups to the study. Deeper insights from behavioral health providers is needed as their patients have relied on telehealth in ways that are different from individuals receiving primary and specialty care via telehealth. Next slide, please. Okay, and one more. So let's talk briefly about the activities that are forthcoming. Over the next 6 months, they include finalizing the 6 briefing papers, analysis of the claims data, completion of the provider survey and consumer engagement interviews, and development of a technical draft final report. Staff anticipates presenting to the commission the draft reports, which includes recommendations for your consideration in the early fall. Next slide, please. So we've done our best to keep stakeholders up to date on what's been going on. Staff set up a dedicated telehealth website to notify stakeholders about the activities. Approximately 100 stakeholders were advised about this webpage. Nearly 30 have subscribed to the listserv to receive updates pushed to them. Updates occur to the website about every 4 weeks. And next slide, please. On January 31st of this year, House Bill 670, Maryland Healthcare Commission study on expansion of interstate telehealth was introduced by delegates Wilkins and Charles. The bill requires MHCC, in consultation with other relevant stakeholders, to study the ways that interstate telehealth can be expanded to allow residents to use telehealth to receive health services from out-of-state practitioners. In lieu of advancing the bill, Delegate Bonnie Collison, chair of the Insurance and Pharmaceutical Subcommittees of the Health and Government Operations Committee, will likely send a letter to our executive director requesting that MHCC complete a study in the interim period on ways to expand interstate telehealth and provide these recommendations back to the committee by December 1st, 2023. Next slide, please. Okay, that was a high-level, fast overview. Be mindful of the time and what's ingestible in terms of the complexity of the study today. Happy to answer any questions.
Questions
Thank
for
you for
David?
the wonderful presentation.
Commissioner Bandari.
David, you said how many physicians or providers are going to participate? About 500 or 150?
So we're looking for a minimum of 500 responses. We're at about 158 now, and this is only week 2. So I think we're doing relatively okay at this stage.
So 500 providers, right? Each provider has to give 1 response.
Yeah, that's the threshold, the minimum threshold. If we get 1,000, that's even better.
Because if I am correct, there are about 30,000 physician providers in state of Maryland. So that's less than 1.5%, less than 1.5% providers are going to, I think the number should be higher than that. That may not give a very accurate information.
So the number that you have is a little high because we're looking at primary care and certain specialists involved in telehealth. So it wouldn't be all, and 30,000 is also, it's more like 26,000 who are licensed. And you have to remember that there's research and working for the federal government. It gets down to about, in terms of active physicians in full-time practice, somewhere in the neighborhood of 16,000. And then we carve out again specialists.
A question about the data part of the study. What are we looking for in that data? Like that part.
So the question is, look, what data are we looking at in terms of the claims? So we're actually looking for services that were provided using modifiers that reflect telehealth, that are used for telehealth purposes, the types of services, the frequency of those services, how many occurred pre-pandemic, how many occurred during the pandemic and the peak of the pandemic, looking across the payers, populations, regions of the state, and then looking at it compared to the government payers.
So it's sort of a longitudinal impact on the use of telehealth throughout the time of the pandemic, though.
Yeah, I think that's a fair assessment of it because we're really trying to gauge what happened in terms of the pandemic, looking at data, and then at the end where we are today, largely.
You may want to, when you're developing those timeframes, talk to the folks implementing it both on the provider side and I think on the payer side, because you're not going to want to do by year, right? Because that's just going to be wildly inaccurate. 2020 is an almost useless year to compare with any other year. But before March 13th, that would be like pre. And there's going to be a period of time when everybody didn't know what to do. And there's going to be a period of time when people are trying to implement things, right? And then there's going to be sort of a new normal-ish. So you might want to make sure those dates, they aren't going to line up with any normal kind of report dates, right? They're
True,
gonna-
and we are trying to drill into quarters to keep it in small chunks as we go forward and back.
So that's what I was, because if we get one that's like 2019, 2020,
Yeah,
2021, it'll be almost useless.
Understood.
Other questions? David, thank you.
Thank you.
There are now only about 25 days remaining in the 2022 legislative session. Based on legislation that's likely to pass, the commission will be asked to take on a number of new assignments and several studies. Tracy DeShields, testifying in the Senate today. Jade Paul, Program Manager, will provide an update and review the bills that are priority for the commission in the next 3.5 weeks. Jade, floor is yours.
Thank you so much. Good afternoon, Mr. Chair and Commissioners. My name is Jade Paul, and I will be providing the legislative update for the current legislative session. Lavon, next slide, please. The legislative session is moving along. Some quick stats. The crossover date is in 4 days on March 21st. At this point in the legislative session, we are closely monitoring bills that are crossing over. With the majority of our bills originating in the House, we want to keep a close eye on Senate proceedings to make sure we stay updated on the progress of our priority bills. There have been 1,488 bills introduced to the Senate and 2,053 bills introduced to the House. Mhcc is currently tracking approximately 188 bills related to the Health Information Exchange, behavioral health, nursing homes, electronic advanced care planning, and proposed studies and work groups. Next slide, please. Ben Steffen will provide a brief budget update for bills in House Appropriations, Health and Social Services Subcommittee, and the Senate Budget and Tax, Health and Human Services Subcommittee. Ben, you're welcome to take over.
Just very briefly, the hearings in both the House and Senate, as we've said at our legislative meetings, went well. There have been no questions. As I've noted, the key issue for the commission, the key issues typically are resolved at the and meetings with the Department of Budget Management or even with the department before our budget bills are introduced to the legislature. And at every stage this year, things have gone well. We expect them to vote the overall budget through in the next several weeks. Both houses. Thanks, Sade.
Thank you. Lavon, next slide, please. MHCC has 2 priority bills, Senate Bill 253 and House Bill 213. Senate Bill 253, the User Fee Assessments Bill, increases our user fee assessment from 16 million to 20 million. The bill was heard in the Senate Finance Committee and the House Health and Government Operations Committee. On March 4th, the bill will be heard in a work session by the House Government Operation and Health Facilities Subcommittee. The bill passed 3rd reading in the House and was referred to Senate Finance. Bill hearings have not been set. However, we will keep monitoring this bill as it crosses over to the opposite chamber. The Health Information Exchange Definition Bill alters the definition of health information exchange to align with the federal definition of a health information exchange. The bill was amended based on feedback from the department. The bill passed 3rd reading and was referred to Senate Finance. We will continue to monitor both bills and take action when appropriate. Lavon, next slide, please. Thank you. MHCC is tracking a handful of bills. Some bills require the commission to conduct either a study or a work group. As denoted by a red asterisk, there are bills that have a fiscal impact ranging from $100,000 to $200,000. The cost would be incurred from employing a consultant to support us as we conduct the study, or the administrative costs for data gathering, surveys, and focus groups. HB 421 generally relates to the provision of behavioral healthcare and services provided by out-of-state providers. Specifically, it authorizes a healthcare provider who is not licensed in the state to provide behavioral healthcare services via telehealth to a patient within the state under specific circumstances. We provided a letter of information for this bill. The bill was heard by Senate Education, Health, and Environmental Affairs Committee and the House Health and Government Operations Committee. HB 636 is one of the bills that require the commission to do a study. The bill requires the commission to work with the Office of Healthcare Quality, the Maryland Long-Term Care Ombudsman Program, the Medicaid Administration, and interested boards and stakeholders to conduct a study on the quality of care at assisted living programs with fewer than 9 beds. We submitted a letter of information for this bill in its crossfile. Both the House and Senate bills are passed and sent to the opposite chamber for first reading. Senate Bill 591 requires the commission to redesignate the Maryland Patient Safety Center in their capacity to develop, coordinate, and implement patient safety initiatives, and to work with stakeholders to improve the overall quality of healthcare across the state. The commission will continue to provide strong support of this bill. HB 378 proposes a work group that would require the commission to study palliative care services across the state. The work group would do a broad assessment of the quality of palliative care available in the state, not only in hospitals, the capacity of palliative care providers, data collection for monitoring, and recommendations for improvement. The commission provided a letter of support for this bill. It passed in the House and would be heard by Senate Finance. SB 734 would establish a new commission, the Primary Care Reform Commission. The commission would focus on primary care spending, specifically developing a standard definition for primary care. It would review and provide recommendations on the level of primary care spending for all payers and how to improve access to primary care to reduce health disparities in the state. We provided a letter of support with amendments and worked with the department to make extensive revisions to the bill. Ben Steffen provided oral testimony. The bill is currently being heard in Senate Finance. HB 747 requires the commission to conduct an annual audit of cost trends, labor issues, and financial performance of nursing homes across the state by way of a survey of the nursing home workforce. The commission submitted a letter of opposition for this bill because the commission already gathers this information in our long-term care survey. This information can be easily accessed on the Maryland Quality Reporting website. After meeting with Delegate Care, the bill sponsor, the bill was amended. It was changed from an audit to a reporting requirement. In the revised bill, the commission would need to continue making this information available on our quality reporting website. The bill was heard in Health and Government Operations hearings. We will keep you updated on the progress of this bill. HB 912 requires insurance carriers to inform members of their right to receive behavioral health and substance abuse treatment from a physician or healthcare provider who is not part of the carrier's provider panel when the patient is not able to find an in-network provider. We submitted a letter of information for this bill. The bill passed favorable with amendments in the House, and the cross-file SB 707 is being heard by Senate Finance. HB 972 allows certain continuing care retirement communities with exceptional comprehensive care facilities that are exempted from the certificate of need requirements to serve individuals if the facility has entered into a continuing care at home contract with the retirement community. We provided a letter of support for this bill and provided written testimony. It passed in the House and was referred to Senate Finance. Finally, HB 1073 requires the commission to coordinate the adoption promotion, and accessibility of electronic advanced care planning for healthcare facilities, nursing homes, assisted living facilities, and managed care organizations across the state. In the interim of 2021, the Commission convened the Advanced Directives Work Group with over 40 individuals representing providers, nursing homes, hospital and palliative care, insurance carriers, and other stakeholders. The Commission provided technical amendments for the bill. It was heard in House Health and Government Operations and Senate Finance. Ben Steffen and David Sharp both provided written and oral testimony. Lavon, next slide, please. Thank you. Ben Steffen will provide an update on activities for our priority bills. Ben, please continue.
Yeah, I'm going to touch on a couple, not all of these, but if you have commissioners have questions, let me know. The first is the House Bill 1148. We call that the Care First bill, but it's broadly a legislation that would allow carriers to establish two-sided incentive arrangements in Maryland. The payers broadly are in support of this bill, and most of the provider organizations have agreed to support the bill as amended. It would assign MHCC a role in the after implementation of these two-sided arrangements to do an assessment of the arrangements that have been established in the state of Maryland. It's it's passed out of the House already and has crossed over to the opposing side, the opposing House. I believe that is correct. It could be vice versa, but it looks like it's going to be passed. The payers have, I think, demonstrated a need for changing the statute to, as we said it earlier today, align with arrangements that already exist in most other states. We've mentioned the previously studies to examine sickle cell and disease. Right now, we've noted that there are about 4 bills that deal with sickle cell disease. This has had a hearing, but we don't know if that's going to be moving. House Bill 1127 is an important piece of legislation for our state designated health information exchange. There have been some minor amendments to that bill that were heard last night in subcommittee. The House is taking the leadership role in moving this. It is only introduced in the House, so it has to pass the House and then cross over to the Senate before crossover date. Otherwise, it would have to go to rules. So it looks like there's general favorability on this, but as it's being heard and acted on late, it will have to have broad support to move. The Delegate Pena Melnick legislation on public health, consumer health information hub and requirements. MHCC is specifically called out in working with the Horowitz Center at the University of Maryland College Park in raising and improving consumer outreach for quality and transparency initiatives. The bill would call for I believe it's a $500,000 annual grant to the Horowitz Center to do that. We did have some conversations with the sponsor about that. And she elected to have the grant awarded directly to the Horowitz Center, which we think is okay. We think that ongoing review of the performance of the Horowitz Center would fall to the legislative committees, which is not typically the way things work, but we assume that this is a priority project of the legislature, and they would keep tab on how these funds are used. As we are one of the quote unquote clients for this, I think it's going to be helpful for us, and we think that's beneficial. Historically, we've worked well with the Horowitz Center, So as I said, we were generally supportive of that. And I think that, that's basically all the bills on this page. I want to bring your attention to, do you have any questions about that? There are several other bills that pertain to Medicaid or to our health benefit exchange. The qualified resident subsidy program would expand who is eligible for insurance coverage under the Obamacare era reforms in Maryland through the health benefit exchange. I think it may be a year or two early for that, but I haven't monitored that real closely, but I didn't see that as necessarily moving this year, but perhaps would be the first step in a multi-year effort to expand coverage. Note that this primarily is aimed at aliens, both documented and those that lack documentation. So it's going to be a challenging financial lift. California initially proposed a similar piece of legislation in 2016. It was withdrawn as it was unlikely the Trump administration would approve it. Clearly the climate in Washington is more favorable to this right now. And it's important to note of the 400,000 uninsured in Maryland, a good number of people fall into this category. But it would be state funds only that would have to fund this, I believe. So back to you, Sade.
Thank you so much, Ben. Lavon, next slide, please. We have 4 study requests from the Chair of Health and Government Operations or Senate Finance. For the expansion of interstate telehealth, this study would assess interstate licensure compacts for out-of-state behavioral health providers who provide care in the state. Specifically, is there adequate flexibility with interstate licensure compacts? The Commission is not opposed to the study, but we would want more flexibility given the scope of work. We have suggested to Health and Government Operations that a request from the chair would facilitate support for this study. We have seen a number of insurance mandates introduced during this legislative session. The Commission has proposed that we use our existing statutory framework under the insurance article to promote consistency for each of the following 3 studies: expanding coverage of in vitro fertilization, HIV prevention drugs, prescribing and dispensing by pharmacists and insurance requirement, and physical therapy insurance copays. These 3 mandate studies would look at the financial, medical, and social impact of establishing new mandates and could trigger a letter from the chairs. We have told the committees this would be a better approach because we can use the existing standard template. We are willing to do these studies, but have not taken a position to support or oppose any of them. HB 625 is an emergency bill. It establishes a study on the healthcare workforce crisis in Maryland, specifically to examine the extent of the workforce shortage, short-term solutions for the workforce shortage, and future healthcare workforce needs. It was passed in the House and Senate with amendments after 3rd reading and will be referred to the opposite chamber for hearings. For other health bills, there are 2 bills, HB 413 and HB 1397. The Market Stabilization Bill encourages people to purchase health insurance through the individual market. It also establishes a framework for funding the reinsurance program in the small group market. This bill was passed in House Health and Government Operations yesterday and will be referred to Senate Finance. The prescription insulin bill limits the amount of members required to pay in co-payments or co-insurance for a covered prescription insulin drug. The focus of this bill is the cost, particularly why the cost of prescription insulin is so expensive. The Commission has not been asked to do a study on this yet. Earlier this week, the Senate bill passed after 3rd reading and was referred to the House Health and Government Operations Committee. Ben, would you like to provide any additional details before we move on?
Just the observation that after about 5 or 6 years in which we didn't see mandate studies, they're suddenly materializing. Again, the reason that we didn't see mandates was principally the result of the ACA, which limited the application of new mandates in the individuals market. But you know, the momentum, these are favorite bills oftentimes of legislatures and key groups of patients that you have identify limitations in insurance benefits. We've suggested rather than bills, we use our authority, which Sade very clearly stated, you use a common template. We do need to hire an actuarial firm to assist us coming up with this assessment. We think we could do it more cheaply if each of these was not specifically carved out. The one that probably has the most impact could be the physical therapy insurance copays, which would put physical therapy on the same framework as primary care. There's an enormous amount of physical therapy provided in Maryland, like other states, and over the last decade, caps have been placed on the number of visits that patients have received that some contend are limiting the copays, which are typically set at the same level of specialist. So if your primary care copay is $25, it's likely your physical therapy copay is $35 or $40. And the provider sector argues that they are much more like primary care than specialty care. I think there are some merits to that, but it is a service that can be heavily used, and I'll leave it at that and study that.
Okay, thank you so much, Ben. Lavon, next slide, please. Thank you. That concludes the legislative update. Ben and I are available to answer any questions.
Questions? Ben, would you like to give us a preview of the April meeting?
Well, we will be returning, first off, the commission staff plans to return to a hybrid work model on the beginning of the week of the 28th of March. That's, of course, as we have said in the past, we've set these plans before. We believe that climate in Maryland with regards to infections are sufficiently low that bringing staff together in a limited way is beneficial to collaboration among the various centers. So on one of those days, all the staff from each of the centers will be in the office, and then they are free to attend another day of each individual person's choice. So that gives us a chance to have each of the centers meet with all of their personnel one day per week. Continue to monitor that as we move closer to that kickoff date, but I'm hopeful we can move forward with that strategy. With regard to the meeting in April, the big news, of course, will be that we'll count the casualties and count the successes from the legislative session. Sine die will have occurred on, I believe it's April. So we'll know what the implications are of that, of this session, and I think it's going to be quite substantial. In lieu of, in alignment with our studies, we're very hopeful that our cap increase is passed, signed by the governor. Keep in mind that the cap increase is not going to immediately move us to $20 million. In fact, I would argue we don't want to move much above our $16 million cap in the first year. We'll do our best to be economical and do that. But passing all of these study requirements without giving us some funding breathing room will make us difficult to execute. And the cap is much like a federal budget cap. But no, don't think of it that way because that's always automatically met in the very first year in which it's passed. But it is like a cap. We take 4 or 5 years to get there. That's what I hope to do this time. So that will be a major presentation. We have one long-standing CON that we hope to bring to the commission. We're bringing it very close to fruition. We will keep you very closely informed as the month advances because that would be one of our contested cases. And then we'll also have our colleagues at Mhcc present their progress on a grant that the Healthcare Commission has awarded to Mhcc to assist in launching care transformation efforts with largely smaller practices in the state that will bring them up to a performance level so they can participate in the various value-based initiatives that the Health Services Costs for You Commission is launching in collaboration with CMMI. And importantly, we are assuming that the so-called Care First bill will pass, is that we can work with our provider stakeholders to enable small practices to participate in the initiatives that the private payers are going to be launching fairly quickly. One of the big challenges with value-based models, as you heard at the outset, is that it's difficult for smaller practices really to take risk, any risk, and that is an essential part of almost all of these CMS programs and could be a feature of some of the commercial programs. And then lastly, the staff is going to listen to what we heard today about how our fee studies can be used effectively, who we need to engage in terms of raising greater awareness on those. It's a tricky business, as I said at one point, but we've worked on payment reform efforts and attempts at setting caps previously. People have left the hearing rooms in tears, and old friends didn't speak to me for a year, and that was on an issue we were on the same side of. So it's tough. It's tough sometimes to get this stuff happen, to move this stuff along. Everyone has strong opinions about this. And, when you talk about payment for small organizations, it quickly becomes very sensitive. But I think we owe it to the commission to come back and say, what are we going to do? We've heard it, from the commissioners in this room, as well as from several that are attending remote.
Thank you, Ben. Questions for Ben? I will, if everybody's so inclined, I'll entertain a motion to adjourn.
So moved.
Commissioner Jensen, second. Commissioner Jordan. Any opposed? Thank you very much.
One final question. I understand that the chair gave dispensation to Commissioner.
This call.
It actually is pretty entertaining.